Good afternoon. Can you see the slides?
Yes, ma'am.
Shall we start? Can you hear me? കേൾക്കുന്നില്ലേ? Can you hear me?
Yes, ma'am.
Okay. After the class, നിങ്ങളുടെ ക്ലാസ് റെപ്രസെൻറ്റേറ്റീവ്സിൻ്റെ വാട്സാപ്പിൽ ഞാൻ ഗൂഗിൾ ഫോം ലിങ്ക് അയക്കും. അത് ഫില്ല് ചെയ്ത് 10 മിനിറ്റ്സിനുള്ളിൽ തരണം കേട്ടോ.
Okay, ma'am.
Okay. Okay, you might have read this news in 2019. No? A 6-year-old boy dies due to diphtheria in our Kerala. The thing is, we have a vaccination coverage above 85%. നമുക്ക് നല്ലൊരു vaccination coverage ആണുള്ളത്, more than 85%. But you see the age, the 6-year-old. Okay. So usually നമ്മളെ immunization schedule പ്രകാരം he might have completed his primary and the booster doses, right? But unfortunately, there's a problem of resistance from some areas against vaccination, and that resulted in surge of these cases, like many of the vaccine preventable diseases like diphtheria, pertussis, whooping cough, like that. Okay, and also the tetanus. Usually നമ്മുടെ vaccine preventable diseases ആണ്. അത് നമ്മൾ യൂഷ്വലി ഇമ്മ്യൂണൈസേഷൻ കൊണ്ട് നമ്മൾ പ്രതിരോധിക്കാൻ ശ്രമിക്കുന്ന കുറച്ച് ഡിസീസസ് ഉണ്ട്. അപ്പോൾ നമുക്കങ്ങനെ റുട്ടീനായിട്ട് കേസ് നമ്മുടെ മെഡിക്കൽ കോളേജിൽ എവിടെയും കാണാൻ പറ്റത്തില്ല. പക്ഷെ ഈ വാക്സിനേഷൻ്റെ ഇഷ്യൂ ഉള്ളത് കൊണ്ട് അല്ലെങ്കിൽ റെസിസ്റ്റൻസ് ഉള്ളത് കൊണ്ട് നമ്മൾ വീണ്ടും ഈ കേസസ് കണ്ടു തുടങ്ങിയിട്ടുണ്ട്. 1 ഇയറിനടുത്ത് ഒന്നും വന്നിട്ടില്ല, അതിന് മുന്നേ ഇടയ്ക്കിടയ്ക്ക് ഇതുപോലെ കേസസ് വരാറുണ്ട്. So our topic today is diphtheria. So what it is? It is an acute infectious disease caused by Corynebacterium diphtheriae. And it is a rare disease in most developed countries because of routine immunization or change in lifestyle. It is a rare disease in developed countries. It is more common in non-immunized children. And this, we see this cases in developed countries more in non-immunized children, and they have got a good socioeconomic conditions as well as immunization coverage. But it is, we can see cases in our country like India. We have cases, but it is shows a declining trend because of this immunization activities. So what are the causes of this epidemics of the diphtheria? One I told you, that is the decreased immunization coverage. And second thing is waning immunity to diphtheria in adult. Usually, നമ്മുടെ വാക്സിൻസ് ഒക്കെ എപ്പോഴാണ് കൊടുക്കുന്നത് യങ്ങർ ഏജ് ഗ്രൂപ്പിൽ ചിൽഡ്രൻ ആണ്. ഓക്കെ, അപ്പൊ ചിൽഡ്രൻ ഒക്കെ ഏകദേശം ഇമ്മ്യൂണൈസ്ഡ് ആണ്, മീൻസ് അവർക്ക് ആ ഇമ്മ്യൂണിറ്റി ഉണ്ട്. ബട്ട് നമ്മുടെ അഡൾട്ട് പോപ്പുലേഷൻ ആകുമ്പോഴത്തേക്കും ആ ഇമ്മ്യൂണിറ്റി കുറയും. അപ്പം വി ക്യാൻ സി ദർ ഇസ് ആൻ ഏജ് ഷിഫ്റ്റ്. യൂഷ്വലി ചിലരിൽ കണ്ടുകൊണ്ടിരുന്നത് കുറച്ചൊരു അഡൾട്ട് സ്റ്റേജിലേക്ക് വരുന്നുണ്ട്. സോ what does it mean? We have to give booster doses for the adult population. That is another thing. Okay. So one cause is decreased in immunization coverage. Second is the waning immunity in diphtheria in adults. They had this immunization in their childhood, but as age increases, the immunity wanes. So there is need for booster doses in adult also. That is another thing. And also, there can be, we have so many migrant people are there, so population is there. So one reason is the population migration. And fourth thing is irregular supply of vaccines. So these are the four main causes of epidemics. One is decrease in immunization coverage. Second is waning immunity to diphtheria in adult population. Third thing is because of population movements. And fourth thing is because of irregular supply of vaccines. So this is the story of this diphtheria epidemics. Okay. In India, there is a declining trend, and with the latest edition of PARC research that in 2018, 11,720 cases of diphtheria were there, out of which 180 deaths. 11,000. So that much cases we have in 2018. And out of which 180 death. And the most cases we see during that period is Assam, Delhi, Rajasthan, and West Bengal. So what does it mean? We have to improve the immunization coverage of those states. Now, next we move on to the epidemiology of the disease. First one is the agent factors. What is a causative agent? You might have learned in your micro classes now about Corynebacterium diphtheria. This a gram-positive, aerobic, non-motile bacilli. And it is, does not invade our invade our bloodstream or anything, but it produces the disease it is caused is because of a powerful exotoxin released by the organism. Okay, does not have any invasive power, but it produces a powerful exotoxin. And there are four types of this Corynebacterium. That is Gravis, Mitis, Belfanti, and Intermedius. It's not written there. Gravis, Mitis, Belfanti, and Intermedius. And Gravis type will produce more severe disease. And another thing is, the non-toxigenic strain can become toxigenic when exposed to a bacteriophage because the beta-phage contains the gene for toxin production. So that way, the non-toxigenic strain can become toxigenic. They are exposed to a beta-phage. And this can cause this affect the heart leading to myocarditis, or it can affect the nerves leading to paralysis. That is the mechanism by how it kills the patient. And it is sensitive to penicillin and is readily killed by heat and chemicals. So that's about the agent factors. It is caused by Corynebacterium diphtheria. It is a gram-positive, aerobic, non-motile organism. It does not have any invasive power, but it produces a powerful exotoxin. Four types are there: Gravis, Mitis, Intermedius, and Belfanti. And Gravis type is more, it produces more severe disease. And sometimes the non-toxigenic strains becomes toxigenic when they are exposed to a bacteriophage. The beta-phage, it carries the gene for toxin production. It's sensitive to penicillin and it's readily killed by heat and chemicals. So now we move on to source of infection. Source of infection can either be a case or a carrier. Case, if we say, it can be either subclinical or frank clinical case. The mild cases usually have the running nose or sore throat, like any viral infection or bacterial infection. We won't even miss. We even miss the mild cases. We don't pick that as diphtheria cases. So the source can either be case or carrier. Cases can be mild, like running nose, and they may present with running nose or sore throat, or it can be frank clinical cases. And the carriers are mainly the cause for, mainly the source of infection, because they are difficult to pick. So the carriers are the most important source. It can be either temporary carriers or chronic carriers. Also the nasal carriers are more dangerous because they usually shed frequently. And these source, the nasal source will shed frequently, and they are dangerous carriers. And there are two types of carriers: temporary or chronic. Temporary means carrier state lasts for a month. Chronic, more than, can last for up to 1 year or so. Okay. So that's about source of infection. Either by case or carrier. Carrier is the most common cause, most common source. Nasal carriers are more dangerous because they shed the bacilli frequently, and the incidence is about 0.1 to 5%. And another thing is, immunization does not prevent carrier state. So that's another thing. That is, immunization does not prevent carrier state. They're giving toxoid, so it does not prevent the carrier state. So next is the infective material. From what all things we can get the disease. This include nasopharyngeal secretions, discharges from skin lesions, contaminated fomites, and infected dust. So the infected materials include nasopharyngeal secretions, discharge from skin lesions, contaminated fomites, and infected dust. Next, we should know what is the period of infectivity. It is 14 to 28 days from onset of disease. That much you have to be careful. That is, period of infectivity lasting from 14 to 28 days from onset of disease. And the carrier length, carrier state can be much longer period. I told you about carrier state, so it can be much longer period. And another thing is, they are considered as non-communicable when at least two cultures that is properly obtained from nose and throat 24 hours apart are negative. Then only we term him or her as non-communicable. So it means they should be non-communicable. We call them non-communicable only if two cultures, and that should be properly obtained from nose and throat 24 hours apart, should be negative. Two cultures should be negative. And these cultures should be taken 24 hours apart from nose as well as throat. Then only we call them as negative. Okay. Now we move on to the host factors. So now we move on to the host factors. So which usually it affects usually the preschool children, that is 1 to 5 years age. About the sex, both sexes are equally affected. No sex predilection, both sexes are equally affected. And about immunity, if they are born to immune mothers, the immunity lasts for first few weeks or months of life. but a few months, or first few months of life. Okay. Next is environmental factors. All the factors, no, all the seasons it can occur, but winter season is more favorable. And next I was the mode of transmission. Mostly by droplet infection, I told you. And also from infected cutaneous lesions. And also from inanimate objects like the cups used by the patient or the thermometer used by the patient or toys. Others can get infection. So modes of transmission mainly by droplet infection or from infected cutaneous lesions or from inanimate objects like toys, the thermometer or pencils used by the children like that. Okay. Next is portal of entry. Usually the respiratory tract. And also it can be from non-respiratory tract like cuts, wounds or ulcers. They are exposed to these bacilli, you can get that from that route also. And incubation period is usually 2 to 6 days. So the host factors, age, it usually affects the preschool children. It has no sex predilection, and immunity lasts for about this first few months of life. And the another thing I forgot to tell, persistence depends upon the availability of neutralizing antitoxin in bloodstreams and tissues. So that we have to check the titers of this neutralizing and antitoxin. And it occurs in persons who have no antitoxin. That is, if it is less than 0.01 Loeffler per ml. So if a person is having antitoxin levels less than 0.01, he is susceptible to this infection. And these are the modes of transmission: droplet infection, and also from the infected cutaneous lesions and inanimate objects. Portal of entry is respiratory, and also from non-respiratory through the cuts, wounds or ulcers. Next is about incubation period, is usually about 2 to 6 days. Now we move on to the clinical features. So in respiratory, we have the pharyngotonsillar, laryngotracheal, nasal, and sometimes combinations. Okay, we have pharyngotonsillar, laryngotracheal, nasal, and combinations. So how this pharyngotonsillar present? It presents with sore throat, difficulty in swallowing, low-grade fever, and the patient will, and if you see the throat, there may be mild erythema, localized exudate or membrane. Or you can see a patch in the posterior pharynx or tonsil, which can cover the entire tonsil, and it can spread up to soft and hard palate and posterior portion of pharynx. And we call it a pseudomembrane. And the earliest early stage of pseudomembrane, it may be whitish in color and may wipe off easily. And later, it may extend to become thick blue, white to gray, and black, and becomes adherent. It won't come off. So, if you try to remove it, it will result in bleeding. And there will be mucosal erythema around it. Okay. And in severe cases, there will be marked edema of submandibular area and the anterior portion of neck along with lymphadenopathy. And we call it as bull neck appearance. Okay. In severe disease, what happens is there is marked edema of submandibular area and anterior portion of neck along with lymphadenopathy. And we have the characteristic bull neck appearance. And the laryngotracheal diphtheria usually preceded by pharyngotonsillar disease. That's extension. So the patient will have fever, hoarseness, and whooping cough, and that is severe. This laryngotracheal is somewhat severe. It usually precedes a pharyngotonsillar disease. The patient presents with fever, hoarseness, and whooping cough. And later the patient will be, it is followed by prostration and suffocation, and the patient may die if we don't intervene immediately. We have to ventilate the patient. So there will be severe breathing difficulty. You have to do intubation and all. Next is a nasal thing. This is very mild. It is localized to septum or turbinates. Nasal diphtheria usually is localized to septum or turbinates. So this is the, you can see the pseudomembrane in the posterior pharynx. It may become very large and obstruct the cover area. So it can obstruct the airway. So this is the pseudomembrane you are seeing. It will bleed if you try to, it will bleed if you try to remove that membrane. This is pseudomembrane. It becomes larger and it obstructs the airway. This is how you get suffocation if you have diphtheria. And this is a characteristic bull neck appearance. So what are features of why we call it as bull neck? Because there will be marked edema of submandibular area and the anterior portion of the neck along with lymphadenopathy. So there is edema of submandibular area and the anterior portion of neck along with lymphadenopathy, which gives characteristic bull neck appearance. And you should know the bacilli inside this membrane have they continue its toxic activity, and this toxin can get absorbed and results in distant toxic damage, especially the parenchymatous degeneration and fatty infiltration and necrosis of our heart muscles, liver, kidney, and adrenals, and sometimes can result in hemorrhage. So it affects what all things? It can affect the heart muscles, can affect the liver, kidney, and adrenals. And these fatty infiltration, necrosis of heart muscles can result in irregularities of cardiac rhythm. And if it affects the ocular muscles, the nerves, can cause disturbance in vision, speech, swallowing, movement of arms and legs, etc. And it can also cause paralysis of soft palate, eye muscles, and extremities. So these are the complications. Okay, these bacilli continue to secrete toxin, and it get absorbed in the bloodstream, and it causes and results in toxic damage and parenchymatous degeneration, fatty infiltration, and fatty infiltration and necrosis of heart muscles. Okay, and it also affects the liver, kidney, and adrenals. It causes irregularities in cardiac rhythm. All these are complications, no? So it can affect vision, speech, swallowing, movement of arms and legs, paralysis of soft palate, eye muscles, as well as extremities. But the complications can recover completely. The patient survives. And I told nasal diphtheria is the mildest form. This is the cutaneous one. It usually seen in tropics. It can cause secondary infection And there can be ulcer, erythema, and membrane formation. And the ulcer is surrounded by erythematous erythema and covered with a membrane. This is the characteristic feature of a ulcer. And other areas it can involve is ocular, genital, and extra auditory canal. So these are the complications I told you. Degeneration, necrosis of muscle can result in myocarditis, difficulty in vision, speech, swallowing, or movement of limbs, and results in neuritis because of nerve involvement. And case fatality rate is about 5 to 10%. That can occur. So 5 to 10% is the case fatality rate. And diagnosis, usually we diagnose it clinically from the characteristics, signs and symptoms. I told you about history. Patient, unimmunized patient or partially immunized patient presenting with so and so features, bull-neck appearance, membrane in the throat, fever, breathing difficulty, then you should suspect any child presenting with these symptoms, you should first ask for the immunization history. Okay. You should suspect case of diphtheria. It's not that uncommon in the cases are coming. So you should know you should keep this as a DD. And laboratory, you can do culture, gram stain as well as serology. That you might have learned in your micro. So please bring that too. The lab motor test. This specimen usually the nasopharyngeal swab you collect. So then we do culture, gram stain, and also serology can do. And next is control of diphtheria. Control meaning the cases as well as the carriers. Cases, I told you, we can it can range from mild cases or the typical or those presenting with typical features. So early detection, that is very important. Early detection of cases as well as carriers is very important. So how can you identify the early cases from among the family members as well as their contacts, especially at the schools or hostels like that? Okay. So the carriers can be detected only by culture method. You have to do culture to detect the carrier stage. And the swabs should be taken from both the nose and throat and examined by culture methods. And it also should test the virulence of the organism. And first step is the early detection, that is of the cases as well as the carriers. Carriers you have to do the culture. And next step is isolation. You have to isolate all the cases, the suspected cases as well as the carriers, preferably in a hospital for at least 14 days or until proved free of infection. So you have to keep them isolated for at least 14 days or until proved free of infection. So who all you need to isolate? All the cases, the suspected cases, or the carriers should be promptly isolated, preferably in a hospital for at least 14 days or until proved free of infection. And I told you at least 2 consecutive nose and throat swabs taken 24 hours apart should be negative before terminating isolation. For under culture, that should be negative before sending them home or before terminating isolation. You should need 2 consecutive negative swabs, nose as well as throats, 24 hours apart. It should be negative. 2 swabs should be negative. And now we move on to the treatment. For cases, whenever we suspect a diphtheria, we give diphtheria antitoxin without any delay. You do not wait wait for the result or anything. If you suspect clinically, you can give without delay. So it should be given IM or IV, and a dose ranging from 20,000 to 1 lakh units or more. Depending upon the severity, you have to give the antitoxin. So dose is 20,000 to 1 lakh unit or more, depending upon the severity of case. So you should do a sensitivity test prior to injection. That is 0.2 ml. You have to give a preliminary test dose of 0.2 ml subcutaneously to detect the sensitization. So in case of mild pharyngeal or laryngeal disease, the dose is 20,000 to 40,000 units. So I told you 20 to 1 lakh. For mild cases, you have to give 20,000 to 40,000. Easy to remember. 22 multiply 20,000 to 40,000. For mild cases, for moderate case, you have to give 40 to 60. 20. So for moderate, you have to give 40,000 to 60,000 units. For severe, extensive or late disease, that is 3 days or more, on a patient present, you have to give 80,000 to 1 lakh units. So how is the dose? 20 to 40 for mild, 40 to 60 for moderate, 80 to 1 lakh for severe cases. And if the patient present late, that is 3 days or more, you don't have to, you are not supposed to give milder doses, low doses. You have to give 80,000 to 1 lakh unit if they are presenting 3 days or more. Okay. So in addition to antitoxin, we have to give what? Penicillin or erythromycin. For 5 to 6 days for cases, and for carriers, we have to give 10 days of oral erythromycin. So what are things we give for a case of diphtheria? You have to give diphtheria antitoxin. That is for milder cases, you have to give 20 to 40. For moderate, you have to give 40 to 60. For severe case, you have to give 80 to 1 lakh. Okay. And for carriers, you have to, along with that, you have to give penicillin or erythromycin. For carriers, you have to give erythromycin for 10 days, oral erythromycin for 10 days. Now, let's see what you should do for contacts. So contacts, they should be throat swab, and their immunity status you have to determine first. They have to be throat swab and their immunity status you have to determine. Now, different situations are there. Okay. First is where primary immunization or booster dose was received within previous 2 years. So, we have 2 years means contact primary immunization of booster dose within previous 2 years. Within 2 years. So what should you do? Nothing is needed. Next case is primary immunization or booster dose more than 2 years before. You have to give booster dose. 1 booster dose you have to give. Okay. Within 2 years, you have nothing is needed. Either booster or primary immunization within 2 years, you are not supposed to give anything. And if it is more than 2 years, one booster dose you have to give. And next case is non-immunized. Close contact. They should receive prophylactic penicillin or erythromycin, and also they should receive diphtheria antitoxin too. That is 1,000 to 2,000 units of diphtheria antitoxin. And another thing is these contacts should be placed under medical surveillance and examined daily for evidence of diphtheria for at least a week after exposure. The patient exposure and we have to check for any symptoms or signs. That is medical surveillance. Okay. So the contact should be placed under medical surveillance and examined daily for evidence of diphtheria for at least a week after exposure. And the bacteriological surveillance of contact should be continued for several weeks by repeated swabbing at approximately weekly intervals. You have to do medical surveillance. Also, you have to do bacteriological surveillance for maybe up to several weeks. And next is for community, what all things you can do. And the only effective control is immunization. Okay, the aim is to immunize before the infant loses its maternally derived immunity, so that there will be continuous protection from birth without any gap in immunity to natural disease. നമ്മൾ കൊടുക്കുന്ന ടോക്സോയിഡ് ആണ്. That is why it does not prevent any carrier stage. And next we move on to the immunization. Okay. So we have different types of methods to give this vaccine. One is combined or mixed vaccines. Examples are DPT, DTPW, that is whole cell, W means whole cell pertussis. DTPA, that is diphtheria, tetanus, and acellular pertussis. Or DT alone without any pertussis component. Small d, capital D, that is the give for the adults. The small d, capital D we use for adults. And also the newer pentavalent, sorry, it is not written there, sorry. And now we give pentavalent for pentavalent. Now we give the vaccination for infants as pentavalent. And the other vaccines, the vaccines included in penta are diphtheria, tetanus, pertussis, that is a DPT component, plus hepatitis B and Hep. 2 more vaccines are there. So we call it as penta. So pentavalent is another combined vaccine, that is diphtheria, tetanus, pertussis, hepatitis B and Hep. And also we give a single vaccines like FT, that is formal toxoid, APT, alum precipitated toxoid, PTAP, PTAP, that is purified toxoid aluminum phosphate, PTAH, purified toxoid aluminum hydroxide, TAF or toxoid anti-toxin floccules. And also we give antisera, that is a diphtheria antitoxin. And this is the first combined vaccine, that is the DPT vaccine, which I told you. Now we give us pentavalent vaccine, I told you already. Earlier we used to give this DPT vaccine. This either plain or adsorbed with aluminum phosphate or hydroxide. So this pertussis, there is an advantage of combining this with pertussis component, because the pertussis enhance the potency of diphtheria toxoid. And the next is about storage. You have to know what is the temperature, storage temperature. It is usually, it should not be frozen, it should be stored in, it should be refrigerated between 2 to 8 degrees centigrade. Okay. And the optimum age is, I told there is maternal antibodies can be there. So optimum age is 6 weeks after birth. And the primary doses usually for DPT is 3 doses. And then we have booster doses at 1.5 years to 2 years, and another booster at the age of 5 to 6 years with the child enters school. So the primary immunization, 3 doses, 4 weeks apart, starting from 6 weeks, that is a 6, 10 and 14 weeks. Then you have the booster injection at 1.5 years, you can give up to 2 years. Then another booster dose at 5 to 6 years. Okay. So Sorry. This is the storage temperature 4 to 8 degrees centigrade. Optimum age starts with 6 weeks, 6 to and 14 weeks, booster at 18 to 24 weeks, and again at 5 to 6 years. Where will you administer? It's administered deep intramuscularly on the anterolateral aspect of the thigh. That is 0.5 ml. Now we see the adverse reactions, that is fever. The patient, invariably the child will develop fever. And also some mild local reactions, that is pain and induration, swelling and induration at the injection site. Sometimes there may be severe complications like um, following DPT immunization. There is neurological complications are also there. That is the encephalitis or encephalopathy, prolonged convulsions, infantile spasms, and Rey syndrome. And it is thought because of the pertussis component. Now the contraindications. Serious mild illness is not a contraindication like fever or cough. There is no contraindication, but we won't give this DPT for those are seriously ill or needing hospitalization or have any previous serious reaction to first dose, that is if the child collapse or shock or persistent ischemia of the temperature is more than 14 degree or convulsions or anaphylaxis following first, you are not supposed to give again. Okay. And in adults, usually we give DT, small d, capital D. It contains this small d capital D contains 2 log plus of diphtheria toxoid compared to 25 log plus in the ordinary DPT preparation. We give small d capital T for adults. Okay. So you should also read about the pentavalent vaccine. It's not written there. The same dosage and all. 2 more vaccines are included. That's all. And next is anti-sera, already told. This we give for passive prophylaxis. And the doses is 500 to 2000 units. Therapeutic is from 20,000 to 1 lakh units. That already told. So that's about diphtheria. Hope all of you understood. Have മനസ്സിലായോ?
Yes, ma'am.
Okay, I'll share the, it's an important topic. You may get case in your practice because in Kerala also because of the lack in the immunization and all. So this is if a child in this age comes with say a sore throat or fever or what breathing difficulty, you should definitely look into this rod for any Tudor membrane. Okay. Also, you should know the dosages, schedule, and storage temperature of the vaccine. Spenda is not written here. We now give it as pentavalent vaccine. Okay. So that's all for today. I'll share the Google links for your attendance to your batch steps. Please share in the group. Okay. I'll give 10 minutes for submitting the responses. And after that, I'll close. So that's all for today. Thank you.
Thank you, ma'am.
Okay. ലക്ഷ്മി ഒന്ന് വരാമോ?